We'll start on this lunch session on keratitis, Kaleidoscope, Asian perspective and practice pearls. So I'm happy to share that we have a very distinguished panel of faculty assembled with us from the Asia-Pacific countries here, and each of them are standalone authorities in the field of cornea and ocular surface practice, and they will share with us their experiences on the related topics they're going to be speaking upon here. So feel free to come over to the floor in case you want to have any of your queries clarified with them here. I will start with the introduction of the faculties with us. We have Professor Dr. Lim Lee, heading the cornea service at the Singapore National Eye Center, and she would speak to us on post-collagen cross-linking keratitis. Professor Radhika Tandon, who heads the RP Center for Ophthalmic Sciences and also heads the Cornea and Ocular Surface Cataract Refractive Services at All India Institute of Medical Sciences, New Delhi, will speak to us on peripheral ulcerative keratitis. We have Dr. Stephanie Watson from Australia, Sydney, who would be speaking to us on contact lens-induced keratitis. Dr. Willowan from Thailand and pythium keratitis. She's done a lot of pioneering work on that, and I think I'll be fortunate to be listening to her from the person itself. And of course, Dr. Revati Rajaraman needs no introduction, a phenomenal cornea ocular surface person heading the cornea services at Aravind Eye Hospital, Coimbatore. And she will talk to us and how the MUT trial has changed the way we are looking at fungal keratitis management here. So this is a slight change in the lineup of talks, as both Dr. Lim Lee and Dr. Stephanie will have to leave for another session. So I think Dr. Lim Lee will first start our session, and she's going to be talking to us on post-collagen keratitis.
Thank you, Prof. Vanathy, for the kind invitation. I'd like to thank the organizers and Prof. Vanathy for the kind invitation to speak today. My topic is post-corneal collagen cross-linking infective keratitis. Here are my financial disclosures. So we all know corneal cross-linking has been FDA approved since 2016, and it's a minimally invasive procedure to arrest keratectasia. The main indications are keratoconus and post-LASIK ectasia. Okay, I won't go through the mechanism. There are various protocols, mainly epithelium off, such as the Dresden protocol, which is the conventional one that we all know about, and then followed by the accelerated cross-linking protocol, transepithelial, and iontophoresis protocol. So I looked up the literature, and there is a systematic review of reported cases of infectious keratitis following corneal cross-linking, published by Professor Alio's group. And in it, they did a comprehensive search from year 2000 to year 2013 to identify all the articles describing infectious keratitis following cross-linking. And they excluded the sterile infiltrates. And they could only identify 10 articles, so it's very rare. Microbial keratitis after cross-linking is rare. Okay, and all these articles, they used the standard Dresden protocol for the cross-linking. So let's look at the infectious cases. The organisms identified, there were 3 eyes with gram-positive organisms, and then 2 eyes with gram-negative. Fungi is in 2 eyes, 1 acanthamoeba, and 2 herpes simplex virus. And all occurred within 5 days of the cross-linking, except for microsporidia at day 6 and fungi at day 30. And the epithelial defect is recognized as the major predisposing factor for the infections. There are other risk factors like atopic disease, diabetes, poor contact lens hygiene, and the latent herpes simplex virus. And 4 eyes had to undergo penetrating or lamellar keratoplasty. Two eyes were infected with fungus, one with acanthamoeba and one with Pseudomonas aeruginosa. So these are the virulent pathogens that are involved that required keratoplasty. So let's look at the hepatic keratitis. Post-cross-linking is usually due to the reactivation of latent herpes simplex virus infection. And the treatment is with topical antiviral agents, should be started immediately along with topical steroid in case of stromal involvement, and oral antiviral in case of reactivation. So patients with recurrent hepatic keratitis should be given prophylactic low-dose oral antiviral in the preoperative period to prevent the reactivation. Here's a summary of the 10 articles that are published, and here's more detailed account. I'll be going through the case reports. So this is the case of infection, a Staphylococcus epidermidis infection, 3 days after the cross-linking, and recovered very well with just topical ofloxacin and tobramycin. And this is a case, a very bad case, Pseudomonas keratitis, 3 days after the cross-linking. And it was treated successfully with fortified cafazolin and tobramycin. However, we required keratoplasty for visual rehabilitation because of the dense central corneal scar following the infection. And this is an interesting case. It's a polymicrobial keratitis after the corneal cross-linking, because this patient, what happens is that he removed his bandage lens and then he washed it with his own saliva. He admitted to it, you know. And so the contact lens grew, strep salivaris, strep oralis, and staph epidermidis. So he had this horrible ring infiltrate that you can see here, but however, is treated successfully with topical cafazolin and ofloxacin. And there's another hepatic keratitis that's reported. You can see the dendritic ulcer there, and successfully treated with just topical acyclovir. And this is a case with a fusarium keratitis, 3 weeks after a healed corneal cross-linking. So even though the epithelium has healed, the patient unfortunately developed a fusarium infection, and this was successfully treated with amphotericin B and voriconazole. However, he needed a keratoplasty for visual rehabilitation. And this is an interesting case. It's a Staph aureus infection. It's a very small infiltrate. It was successfully treated with topical ofloxacin. And because the scar results in significant flattening on the cornea, the patient had a big improvement in the visual outcomes. So the infection did improve the patient's visual acuity after cross-linking. This is another case of hepatic keratitis with the iritis. There's a geographic ulcer there, all right, and is successfully treated with oral acyclovir. And this is the patient with acanthamoeba keratitis. What happens was that the patient was not aware that he was wearing a contact lens, and he washed his face regularly with tap water. So he ended up with a very bad, severe acanthamoeba keratitis, that resulted in corneal perforation, requiring a tectonic keratoplasty. And this is another case of gram-negative E. coli infection. You can see the multiple infiltrates mid-peripheral that recovered well with topical fortified tobramycin and cafazolin. And there's also a microsporidial keratitis at day 6 of the infection, and is successfully treated with topical Vigamox and albendazole 400 milligram twice a day for 6 weeks. And there's another review article looking at, I just wanted to show you the sterile infiltrates. In a prospective study, 117 eyes reported to have 7.6% sterile infiltrates, and is associated with vernal keratoconjunctivitis, so must be careful, all right, if you have a VKC patients, they can have variable patterns. They can even have a shield ulcer following cross-linking, and majority resolves with topical antibiotics and intensive topical steroids. And sometimes you may need to debride the vernal plaque. And so it's very important that we must control VKC at least 2 to 4 weeks prior to cross-linking, and do not perform the cross-linking when there's an active VKC disease. So in another retrospective study, 771 eyes, there's a 1.4% of peripheral ulcerative keratitis, and it's late onset, 3 months to 6 years. So our cross-linking patients always bear in mind it's possible to have, there's a 1.4% of PUK incidence, And if you treat it with topical steroids, it can usually resolve within 1 to 2 weeks. And there's another case report of DLK after cross-linking for post-LASIK ectasia. So for the post-LASIK ectasia cases, bear in mind there's an increased risk of DLK. So in summary, cross-linking is relatively safe with low complication rates. The infective keratitis is rare, and the outcome depends on the causative organism. There are pre-existing conditions that can pose significant risk factors to complications, such as VKC, atopy, hepatic eye disease, prior LASIK, diabetes, and autoimmune conditions. Thank you for your attention.
Thank you, Dr. Limley. And yes, Dr. Larkin.
That was
yes.
a really good presentation. We're all seeing these patients now, but this is an Asian keratitis perspective I'm looking at, and I'm a European visitor. So is there anything different in the Asia-Pacific region in post-cross-linking keratitis? I'm expecting to see lots of fungal keratitis and not much else, but maybe I'm wrong.
Yeah, I think in general, in the tropical country, the incidence of infective keratitis will be higher, whether it's post-cross-linking or contact lens or yeah. So I think you will see a wide variety, not just fungal. It depends on the region. Certain regions will have more fungal, and certain regions will have more bacterial keratitis. So that's a wide variety seen here.
One question, quick question. For Seals ulcer, what is your steroid of choice? For the Seals ulcer, which steroid do you use?
So actually, after cross-linking, typically we just give, like for example, in my clinic, I just give Vigamox and steroid.
My question for Seals ulcer, which steroid do you use?
Sorry?
For Seals ulcer, sealed ulcers in that.
Oh, okay. For shield ulcer, if you get a shield ulcer, usually we consider it is sterile infiltrate. So you will just cover with broad spectrum, antibiotic plus steroids. Yeah. And you may have to debride the plaque if you get it.
Which steroid do you use? My question is, which steroid do you use?
Preservative-free dexamethasone. Preservative-free dexamethasone. Yeah.
And one thing more, for which quinolone you are using ofloxacin?
No, here we use the, in Singapore, we have the levofloxacin that is available, as well as the Vigamox. Yeah, so because those are preservative-free eye drops. So we prefer to use the preservative-free.
Getifloxacin 0.5%?
Sorry?
Getifloxacin 0.5%?
Yes, that one, I think getifloxacin might have some preservatives there. You mean the Zyma, right? I think it's got preservatives.
Yes,
Yeah.
it has.
Yeah.
Yeah. I think what the protocol which we do follow at our center is that we always get a conjunctival swab done so that we are just a couple of days before the procedure is scheduled, so that we make sure that the ocular surface is free of the load of organisms. And another another protocol which we also follow is we have the bandage contact lens put in, and we avoid steroids for the first 48 hours till in 48 to 72 we see the patients after that. And then once the bandage contact lens is removed, we then institute or we initiate the steroid therapy. That's how we do it. But then the fine line is differentiating between sterile infiltrates and infective infiltrates. But for all practical purposes, even if you're sure, you would probably treat the first 24 to 48 hours of infiltrates as an infective infiltrate here. So that's the dictum we would always, because we don't want to err on the side of infection most of the time here. And when you have cases with allergic conjunctivitis and vernal catarrh, those are surfaces which are particularly prone for inflammation following this procedure here. So we'll probably be more stringent in our schedule when we'll control the surface inflammation before we would like to take the patients on.
Our experience is for Seals ulcer, typical atopy.
So I think those were some of the publications which she was speaking about. So and that was a case where the Shields ulcer occurred following collagen cross-linking. So probably it was a very florid, it was not a quiescent surface before they took it up here. So that could be one of the cases here. She was not sharing her experience, but she was quoting review of literature in that one. Okay? Yeah. Sure. Thank you. And then we will move on to Dr. Stephanie Watson's talk on contact lens induced keratitis. Over to you, Stephanie.
Thank you, and thank you for the invitation to speak in the session. I'm glad to be here, and I've got no conflicts of interest. So people wear contact lenses for a variety of reasons: to correct refractive errors, as an alternative to spectacles, or because they can't wear spectacles if they have irregular astigmatism, for therapeutic reasons, to heal defects, following surgery, cosmetic reasons. Such that the global market for contact lenses is actually huge. It's worth about 8.6 billion US, and it's growing at a rate of close to 10% per year. Now, in a survey, between 23 to 94% of contact lens wearers reported discomfort and eye problems. And in a third of these contact lens wearers, they'd visited a physician at least once due to a painful eye. Now, with the huge number of contact lens wearers out there, it means that we'll likely be seeing these cases of contact lens related issues in our clinics. And in fact, looking at overall at cases of keratitis in some studies, around a half are actually associated with contact lens wear. And the risk of keratitis with contact lens wear has been estimated to be increased up to 80 times. The incidence, though, is said to be around 2 to 4 per 10,000 per year, with most organisms bacterial, though acanthamoeba and fungi have also been identified. The number of patients that end up with permanent damage is less than those affected in total, but it's still around about 0.6 cases per 10,000 per year. Now, in our Australian data, when we looked over 5 years at our cases of microbial keratitis that had all presented to the Sydney Eye Hospital, which is a quaternary referral centre, 63% had a history of contact lens wear. Even in this group, gram-positive organisms, particularly coagulase negative staph, was still more common, though we did find Pseudomonas as well. In this paper from a while back, and Dr. Allen was here just a moment ago, we actually looked at the risk of LASIK surgery. And if you think about contact lens wear, while you're wearing the contact lenses, every day there's a risk. Whereas with LASIK surgery, you take that risk all at once. So if we think about contact lenses, there's different types, and the incidence of keratitis varies with the different types. It's lowest with rigid gas permeable contact lenses and highest with overnight wearing of soft contact lenses. Now, there's a number of risk factors that have been identified in relation to contact lens related keratitis, and this table is from a review paper that's included many studies on keratitis, and it found a range of different risk factors with excessive or overnight wear, increasing the risk up to 15 times, poor hygiene, water contact, no hand washing, increasing up to 11 times, swimming in contact lenses, which we see a lot of in Australia, particularly if you're quite myopic. It's very hard to find your beach towel when you come out of the ocean if you don't have contact lenses in. So it's very hard to get people not to swim in their contact lenses. Smoking, male sex, people that don't have experience with contact lens wear, those of younger age and socioeconomic status all had increased risk, as well as hyperopes and people that ordered contact lenses online. And some of these will be cosmetic contact lenses. In this survey of 1,000 contact lens wearers conducted in the US, we can see that many patients are not fully compliant with what's needed to maintain good contact lens handling practices, such that only 1% of patients reported following all directions for contact lens wear. And around half occasionally wore the lenses overnight. Over half wore the lenses for longer than recommended. 85% showered in the contact lenses. 60% swam. And a significant proportion actually stored their lenses in tap water, which is a risk factor for acanthamoeba. Even in children, we see contact lens related keratitis. This is data from our series of patients in Sydney of pediatric microbial keratitis. And in our 80 patients who'd had keratitis, 26% were contact lens wearers. Some of these children may have been aphakic and needing to wear contact lenses for that reason. Others were wearing them for refractive purposes. And again, in this series, gram-positive bacteria were most common, though we also did isolate Pseudomonas. We also reported on travel-associated keratitis. Another group we see contact lens-related keratitis in Australia is people travelling, either travelling in Australia or Australians travelling overseas. We have backpackers that spend time going around Australia in vans, and they usually come in without access to tap water, using stored water, and they'll have infections. And Australians going to overseas tropical destinations have an increased risk for Pseudomonas-related keratitis, and there's an increased risk of resistant organisms. When we looked at 26 patients that had travelled 2 weeks prior to presentation, we again found most of them had gram-positives, but there are also significant numbers with Pseudomonas, MRSA, and fungal and nocardia infections, one of each. Now, in thinking about contact lens-related keratitis, it can either be contact lens-related peripheral ulcer or a microbial keratitis, and you distinguish between these based on symptoms and signs. In contact lens-related peripheral ulcer, there's epithelial excavation and infiltration, but Bowman's membrane remains intact. There may be mild and localized conjunctival injection. The infiltrate is typically small and has rounded edges or is oval and is white or white-grey in appearance. And as the name suggests, it occurs in the peripheral cornea. There doesn't have to be an epithelial defect or erosions, and it can occur in up to 2 to 3% of daily silicone lens wearers, and more common in extended lens wearers. Patients can even be asymptomatic, so you might see it on examination without the patient reporting symptoms. And this is thought to be an inflammatory event associated with bacterial colonization of the contact lens surface with gram-positive bacteria. And it typically resolves once the contact lens wearer is stopped, but occasionally might require steroids. Now, more serious is contact lens-related microbial keratitis. And as I've said, it can be caused by bacteria, fungi, viruses, or parasites. And it's defined because the contact lens wearing is thought to be the main risk factor in the keratitis. Now, there's been a number of theories around why contact lens-related keratitis occurs, relating to factors that have been affected in the normal ocular surface host defense by the contact lens, such as the reduced physical clearance of microbes, interference with natural tear antimicrobial activities, effects on the epithelial cells, and also effects on the tight junctions. Now, in this diagram, it's attempting to show the difference between what happens in a healthy corneal surface, and this is from Susie Fleischig's paper in Progress Retinal Eye Research, as opposed to a contact lens wearing patient. So in a contact lens wearing patient, you might have microbes on the contact lens. And when you've got a keratitis, these might be in what's called a biofilm. And this means that the organisms there are less susceptible to the host response. There's increased inflammatory cells available to start an inflammatory response, and there's some desquamation increase of the epithelial cells. Okay, now Pseudomonas, as we've heard, is a common organism in contact lens-related keratitis. And this is thought to be for a number of reasons. One, it has a very large genome. And so this means it can have many genes that are devoted to it being virulent, devoted to it being able to survive and adapt. It's ubiquitous in nature. It's a water bug. And so it's common when contact lens wearers are handling or cleaning their lenses in a bathroom, that there's likely that Pseudomonas might be around, and it's highly immunogenic. So what do we do if we see a patient with a contact lens-related keratitis? Well, it's really to start with the a management that we'd do for any keratitis case, which is going through this regime of, first of all, documenting what you have and then starting treatment. First of all, look at the amount of thinning, an epithelial defect, infiltrate, hypopion. Perform a corneal scrape And this video here is a video we produced based on the evidence that you can use to increase the likelihood of getting a result from a scrape. Important things are to take the plates out of the fridge an hour before plating the specimen, and to not embed the organisms within the plate. Now, the reason it's important to try to get a scrape result is that there's many organisms that can cause keratitis, including contact lens related keratitis. And in our review in 2012, we found around 232 species, and by 2019, this had increased to 688 species. So you have to bear in mind there might be more than one organism, or an organism you're not familiar with. So the best way to choose your antimicrobials is based on your local epidemiological data. And we've been collecting our data in Sydney and now nationwide. And this is called the Bacterial Ocular Surveillance System. So once you know you're selected your antimicrobial, you do a sterilization phase where you give the treatment frequently, hourly for 2 days, day and night, and I'm almost done, and continue hourly for 3 days after assessment. Modify it, review at 48 hours. Now, if things are getting worse, then you have to think about the possibilities of progressive keratitis. And in contact lens wearers, this can be due to acanthamoeba keratitis. And in Sydney, over 15 years, we found that there was 83% of patients with acanthamoeba had worn contact lenses. And for fungal keratitis, it was 20%. We found that some of these cases occurred in patients wearing orthokeratology lenses. So this is a risk factor, particularly if they clean their lenses in water. And this was reported in the New York Times. So in summary, contact lens related keratitis is keratitis associated with contact lens wear. It has many underlying risk factors, so we need to warn all patients of the risk when they wear contact lenses. It's mainly bacterial, so begin treatment with the most likely antibiotics for your region that will cover the organism. But if things progress, consider acanthamoeba and fungi, because prompt treatment can save sight. I'd just like to thank Maria Carrera-Argos in my research group, who does most of the work on keratitis. She has a great podcast around that. Thank you.
Thank you, Dr. Stephanie. I think anyone who would like to have any more queries or clarifications? Yeah. Yes. I think if not, then Stephanie, a question from me is that Dr. Stephanie, what do you see which is more common in your state? Do you see more of Pseudomonas? Do you see more of acanthamoeba when you are looking at contact lens induced keratitis? And I know there is an increased adoption of orthokeratologies these days, talking about myopia control, which is now taken in a very big way, especially in the Asia Pacific countries. So what do you think, how has this changed the perspectives of contact lens induced keratitis?
Yeah, so with the orthokeratology, because of the work on myopia, we're seeing patients present younger with contact lens related keratitis. And because of the tap water cleaning, we're seeing children present with acanthamoeba keratitis, which we haven't seen before. This has been relatively new and increasing with the increased use of orthokeratology. Acanthamoeba we don't see that much. It's not that common. We do see it in people that have travelled to the UK, where it is more common. And generally it's people swimming in contact lenses in spas, showering in them. Pseudomonas we still do see a fair amount, not just in contact lenses, but also in the elderly with compromised ocular surfaces. So it, and particularly leads to very rapid progression.
Thank you, Dr. Stephanie. And we will now move on and invite Professor Dr. Radhika Tandon to talk to us on her experiences of peripheral ulcer keratitis.
Thank you, Vanity. Thank you for inviting me to participate in this course. So, peripheral ulcerative keratitis, I'll try to give you the Asian perspective and practice pearls. Largely, the principles remain the same, universally what is globally followed. One cannot emphasize more the importance of a very careful clinical evaluation and then appropriate investigations and surgical planning. But largely when you get a patient with peripheral ulcerative keratitis, it involves getting the systemic diseases investigated for and look for comorbidities and titrate your medical management, because often it requires systemic treatment which can have a lot of side effects. It's a step-up approach and a sort of tailored approach depending upon what the underlying disease is. But always remember to rule out infection first, because it may not be a primarily infective cause, but because of the ulceration and the abnormal commensals on the eye, the patient may have an associated infection. So irrespective of it showing a very classical appearance of a PUK, don't start the steroids on the first day. So this I would say from an Asian perspective. Nothing is going to happen if you delay the steroids a day or two, but if there's an associated infection, it can flare up. So do the microbiological investigations first. Call the patient back after 48 hours. Tell the patient that this is the situation and this is what I'm going to do, and then reassess. And when we're treating, the aim is to get the ulcer to heal, and you have to control any of the systemic diseases which are the underlying immunological cause. And systemic diseases, systemic involvement would of course depend on what is the underlying disease, and there's a whole host of medications that one would use. But if essentially steroids are the mainstay to start with. So whatever other immunomodulating drugs are going to be given, they're going to take a little time to act. So right in the beginning, the systemic steroids are going to be the mainstay, and then simultaneously you start the other treatment and so on. Surgical principles, of course, if you have an ulcer of such extent, then you have to go for surgery and reinforce, support the cornea. And depending upon what tissue is available, one may use cornea, one may use limbus, amniotic membrane, even a Tenon's patch graft. The important thing is to seal that opening as soon as possible. Clinical scenarios for corneal tectonic support, of course, would be thinning, melt, perforation, and descent to seal. The reason I'm emphasizing this is because a lot of people are not comfortable doing this surgery, and unfortunately, this is what requires to be done as soon as possible. So if one sees this, and if you're not going to be comfortable doing the surgery yourself, then you have to immediately refer to a corneal surgeon. I just give you a few examples of some case studies. The use of AIOS-OCT is very useful to assess, and then you look at the etiology, the extent, the comorbidities, the systemic condition, and then try to stabilize it with medical treatment before going straight away to the OR, and then surgical treatment and rehabilitation. Now to come for a few examples. So this is a 45-year-old unmarried gentleman who was admitted. He did give a history of high-risk behavior and was a chronic alcoholic. These are questions which were asked later on. He had vision of 5/60 in the right eye and had movements close to face in the left eye. So he had iris nodules, there was a pupillary membrane, he was aphakic but no history of previous surgery, and then he had these scleral nodules which is suggestive of nodular scleritis in one eye, and on the other eye he had this perforated PUK and associated necrotizing scleritis. So to the bilateral disease, there was an element of PUK with scleritis, there was anterior uveitis and aphakia, and on systemic evaluation he had a genital ulcer which was single oval shaped, painless and indurated. Ultrasound showed that both eyes there was a posterior dislocated crystalline lens. There was no history of trauma or any previous surgery. We started, as per our protocol, we started initial treatment with fortified antibiotics, and we tend to give vitamin C and doxycycline as stabilizing influences in these cases. And it was simply that because he'd had a history of some time, and there was a scleritis, and until we waited for the microbiology results to come, we started him on oral ciprofloxacin with ranitidine. Systemic investigation showed that this was our differential diagnosis: tuberculosis, syphilis, and eventually he had a mild splenomegaly. His LFT was partly delayed. That could have been because of the alcoholism. And while we were getting all these investigations done, he started improving. So he improved remarkably without any surgery. His vision improved to 6/9 and 6/60 in the left eye. And eventually we thought it was some kind of syphilis actually, which is believed to respond to ciprofloxacin. So we never able to come with a definitive diagnosis, but that is what it seems to have turned out to be. There's another patient was a 47-year-old male. He had been diagnosed with Sweet syndrome previously, which occurs with tuberculosis, and he came back. He came to us with sclerokeratouveitis and secondary glaucoma. And this is what he looked like. There was a POK. There was an associated, again, these multifocal nodules necrotizing and evidence of an associated scleritis. And since he was known Sweets, which we know is an inflammation related to tuberculosis, and we saw this, so we started him on topical steroids. And this is what I want you to think back when I go what I said in the beginning. And he showed a remarkable worsening with the steroid therapy. In fact, he progressed to necrotizing scleritis with a worsening of the POK and an exudative RD. So immediately we stopped the steroids. It was Sweet syndrome, and it was actually turned out to be primary ocular tuberculosis. So he had to be started on ATT for 9 months with topical lubricants, cycloplegic steroids, and antibiotics, and he completely healed. One more patient to share, 26-year-old lady. She had a history of gradually developing a whitish opacity and diminution of vision of both eyes for 5 years with an intermittent occasional dull pain, some redness, and she was provisionally diagnosed as having disc edema. She had scleral thinning and hypotony, and her vision was poor of 2/60, 3/60. And MRI brain had shown hypophysitis. So she seemed to have this kind of a non-ulcerative perilimbal keratoscleromalacia. It's felt to be an idiopathic non-necrotizing scleritis with hypotenuse maculopathy, and we really didn't know what to do with her. Unfortunately, there were these cystic spaces with uveal show, but it was all intact. There was no leakage, there was no serals positive, but it was progressive hypotony maculopathy which kept worsening. And so finally a bilateral overlay corneoscleral patch graft was done, surgical treatment, and the patient responded well and recovered vision. This is an example of how one could do a simple patch graft, and one thing interesting is you see any presentation on POK or scleral melts, it's very interesting to see that they all look the same, irrespective of what the underlying etiology is. But the reason I'm showing this picture is because I feel that glycerine-preserved corneas can be very good emergency tissue to have in places which don't have immediate access to an eye bank, and this kind of surgery is not very difficult to learn. So I feel that often these patients can be saved by more surgeons are willing to take up these kind of measures. Another thing I would like to share is that one can also do a lamellar patch graft in such patients. You take a thin sliver of the cornea, thin it down, and apply fibrin glue on the exposed surface, and then just apply the patch. So this is a temporizing measure that you can do before you send the patient to some other center. And of course, Tennant's patch graft is another emergency autologous Tennant's patch graft which can be done in such cases. So this is the example of how the patient looked. This was the glue-assisted patch graft in a patient with a peripheral corneal melt. And a similar principle can be used if it's a POK. So sutureless patch graft for sterile corneal melts can work very well in such situations. You assess the perforation, look at the extent, and look at the options. And even amniotic membrane can be used as a temporizing measure in some situations. So conjunctival resection, amniotic membrane, onlay or inlay grafts, optical keratoplasty, and keratoprosthesis is the armamentarium that one can have to restore vision in such patients. But generally follow an algorithm. If the perforation is less than 4 millimeters, one can try simple glue with BCL. If it's more than that, then one has to apply a patch. Look at whether it's sparing the visual axis or involving the visual axis. And accordingly, if it is involving the visual axis, try to do a glue-assisted patch graft rather than suturing it. So therapeutic and tectonic role of patch grafts cannot be overemphasized in such patients. Good photograph, AIOS2025, and later on in vivo confocal microscopy could be useful to have a better understanding of such patients. Do you have time to share 2 more quick cases? But there was a 13-year-old lady, a girl actually, who presented with bilateral diminution of vision, which had redness, pain, photophobia, lid swelling, and purulent discharge for 10 days. She also had noticed ulcers on the oral mucosa, scalp, hand, foot, and genitalia for 9 days, and had consulted a local doctor who presumed it to be gonococcal mucopurulent conjunctivitis, for which she was treated with topical and oral antibiotics, but showed no improvement whatsoever. So she presented to our eye emergency after a week. So she was admitted. This is the nature of the lesions she had in other parts of the body, and this is what the eye looked like. She was taken up for examination under anesthesia because she was not allowing the left eye to be examined, and she had marked congestion and a severe peripheral 360-degree corneoscleral melt. There was a nasal symblephron. This is what the right eye looked like. This is what the left eye looked like. And there was a nasal scleral melt and a 360-degree peripheral ulcer with the central cornea was clear. All the systemic investigations turned out to be negative, where there was a high suspicion of Behçet's. So she was started empirically with the dermatology and immunology consultation with tablet dapsone, azoran, and Visalone. And the left eye was taken up for surgery under general anesthesia, for which symblephron release with the corneoscleral patch graft. A very extensive 360-degree surgery was done. And on here again, I would emphasize, if the central cornea is clear, don't try to do a sclerocorneal graft in such patients. It may seem very messy at the moment, but if you see what the patient ended up later, you would realize that it made sense to save the central cornea. And 4 days later, she developed a small peripheral ulcerative lesion in the right eye, for which topical steroids were prescribed. And on 8th day, there was a wound gaping at the left eye, again at 11 to 1 o'clock with uveal tissue prolapse, for which a repeat procedure was done. And the vision had improved to about 5/60, and the patient really responded well to treatment. So this is how she looked later on. So this is again, I mean, it's not looking too great, but I feel it's better than what would have happened if you had done a corneoscleral patch graft corneoscleral graft straight away. And this is the long case, so I'll stop here because there's a whole lot of interesting cases, but I would suggest that whenever you see a patient of PUK, a very careful history, and sometimes you have to ask the patient because they don't come up with things which they think, you know, is not related. So you really have to ask some pointed questions and get all the investigations done, and sometimes it doesn't fit in with what's reported. So you have to, you know, just titrate your treatment, see how it's going, and then decide what to do next. Thank you.
Thank you very much, ma'am. I think that's a wonderful compilation of experience on managing peripheral ulcerative keratitis. And I think, Willowen, you can set up your slides as Dr. Radhika can take questions from the floor. Anybody who would like to have any clarifications, any queries, yeah? So I think from our experience, peripheral ulcerative keratitis need not always be an infectious keratitis. So the immune component always needs to be looked at here. But several times we tend to jump to the conclusion of Moran's, which is a conclusion of, which is a diagnosis of exclusion here. And looking at infections, systemic infections, which would probably are affecting and manifesting at the limbus, is something which is which needs to be at the back of our mind, and these are very difficult scenarios to treat. Dr. Larkin.
There's some excellent advice, and you've got lots of experience. And I find that the most difficult management question in these patients is when to use systemic immunosuppression. You've excluded infection, or you think it's not infection. And I must say, based on my own experience, they're the very difficult patients. But thank you very much. Very excellent.
Thank you so much.
I think I agree with you, Dr. Larkin and Dr. Radhika. So I did have one immune peripheral ulcerative keratitis in an elderly gentleman who keeps becomes quiescent after his primary management, has a peripheral patch graft, and then keeps coming back every 6 months with a breakdown of the ocular surface. And perhaps these are the right kind of cases where you would want to put them on immunosuppressant therapy. But given the age in these patients, given their other systemic comorbidities, and given that it's more life-threatening in these, we probably have to strike that fine balance of whether we want to have a continued or a chronic immunotherapy. So that's always a question which is there on the back of our minds, and that does compromise the management of the ocular surface in these cases. Dr. Willowen, yes.
Yes, thank you very much. I would like to thank Professor Vanity for inviting, and I don't have any financial interest to be declared. Pythium insidiosum is an aquatic fungal-like organism which resides in the inland water. It belongs to the phylum of Oomyceta and class of Oomycetes. It loves stagnant and clear water. And it can be induced to form the zoospore, as you see in this video. And when the human injured surface is exposed to water, this little infective zoospore will penetrate into the tissue, multiply into a mycelial-like structure and cause the keratitis in the patient. Okay, the first report of Pythium keratitis definitely is from Thailand. It was in 1988, and since 1993, Pythium keratitis has been identified and reported from around the world, with larger series from India recently. And the predisposing factors are the trauma with the water or natural substance contamination, contact lens wear. Since 1985, human pitheosis has been reported from every region of Thailand, as shown in this map. It has 4 clinical forms. 3 of them are systemic infection and often associated with underlying disease, mainly thalassemia, and has worse life prognosis. But comparing to ocular pythium, in contrast, they don't have any underlying diseases in all reports. Pythium keratitis is a unique infection. It becomes our interest because of the aggressive nature, unresponsive to treatment, and often lead to poor visual prognosis, which more than half of them receive globe removal. The diagnosis is made by clinical pattern, culture, PCR, IVCM, and unique histopathological finding. So I would like to share with you some of the pictures of the typical Pythium keratitis. As you see here, especially at the border, if you see it, you can observe what we call the tentacle or reticular edge patterns, which is very typical, just like in these slides. And that slide also. That one is after the biopsy. And you see the reticular pattern, right? So this is very unique. If it's come in an earlier phase, you can see as in the left-hand pictures, but in a confluent cases like this. In 2021, our group published a series of 26 eyes in 25 patients with Pythium keratitis, and showing that there were 4 types of infiltration. The first one, reticular type, which is at the early phase of the infection. And then when disease advanced, it can progress into a satellite type, the multifocal. It can be a dense total infiltration, as seen in this picture. Another unique presentation is that if unrecognized and untreated, it will progress rapidly within days, as shown in this picture. So within like 5 or 6 days, the lesion can progress rapidly. Definite diagnosis of Pythium keratitis can be made, especially when you use just the normal, the routine blood agar culture, because the microbiologists often do notify the clinician reporting a rapid growth of mold on the blood agar, which is definitely not the contamination as seen here, and as well as in the subrodextrose agar. The cotton blue staining show a hyphae structure, and in the IVCM, multiple hyperdensity lines with interlocking and branching hyphae-like structures in the stroma of the cornea, as in this picture. Of course, the PCR is a definitive diagnosis for Pythium keratitis, and if you can take culture and force it to form a zoospore, so that is another final diagnosis. Recent study from India show a new diagnostic staining techniques, which they use the iodine, potassium iodide, sulfuric acid staining. And this technique can differentiate Pythium from the fungal keratitis. The Pythium will stain blue, as in the picture C, D, and E, while fungus will stain brown in the F. Histopathologic features of the corneal button often show the branching, sparsely septate, and short hyphae varying in size and diameters along the corneal lamellae, as seen in the H&E staining. The hyphae will show and will stain vivid black by the GMS staining, and the higher density of the organism was associated with the high risk of globe removal. This is our recent patients coming with pythium keratitis. And in this case, we just diagnose by the clinical presentation. And we don't have to wait for the report of the laboratory report, but then we start the patients right away with the medicine. As you see, the KOH, the septate hyphae, and the IVCM is nothing to be differentiated from the fungal keratitis, and we perform the therapeutic PK, and that is the GMS staining of the pathology. Well, from our report, we also try to find the risk factor, and these factors were proven to be the risk for globe removal, which are older age, positive history of ocular injuries, positive history of eye contamination with agricultural substance, longer duration from the disease to the first medical treatment, infiltration size which is larger than 6 millimeters, the infiltration patterns of anything else except the reticula, the early stage, and the dense filament from the histopathology. And with the medical treatment, what is the treatment? If you treat the patients early enough at the early stage, the use of azithromycin eye drop and oral, or the clarithromycin linezolid can be used to treat pythium. And there is a paper showing that the combination of topical linezolid and topical azithromycin was more effective than topical linezolid or the monotherapy alone. In our series, all cases received the TPK, and there were very high incidence and poor visual outcome. So we have like 58% of globe removal. But compared to the series from LVPI, which is in 2023, the best they report so far the best outcome because they can preserve the globe within 98%. I think these factors are really related to some of the reasons. First is that they made the very early diagnosis and start the treatment right away. The second thing is that if reviewed to the series, their lesion is at the early stage. And so I think the very important is that you have to diagnose pythium keratitis as soon as possible and start the treatment. So in conclusion, pythium keratitis is a very unique and progressive sight-threatening diseases. Rapid diagnosis using a combination of clinical, staining, and culture. Therapeutic PK in our hand is a primary gold standard of treatment and should be prepared and executed whenever the progression occurs. The medical treatment alone may be effective with a combination of topical linezolid and topical azithromycin, and it can give a favorable outcome in the patients. I would like to thank my team at King John Gun Memorial Hospital, fellows, and all the residents. Thank you.
Thank you, Dr. Willuan. And any questions for Dr. Willuan as Dr. Revati sets up for her talk? Yeah. I think pythium has always been something which we probably were missing earlier because it looks very much like fungal, and we tend to misdiagnose at fungal here, but then it behaves like a bacterial ulcer. It progresses very fast. Yes, we have a question for you.
Ma'am, how to practically differentiate between tentacles of pythium keratitis and feathery margins of fungal ulcer? Like, we tend to confuse. How you say it is tentacle and how it's like feathery margins?
Can you please repeat the question, please?
She was asking, how do you differentiate the tentacle margin of pythium from the feathery margin of fungal?
Well, I think with fungal keratitis, the margin will be some kind of fuzzy. Sometimes you can see like the extension out. But for pythium, it's really a tentacle. It is something like branching, and then it just go into reticular pattern. So if you observe and you see several cases, and you will be able to kind of think about pythium keratitis. The next thing is that it is very rapidly progression. Comparing to fungal, you need like 1 or 2 weeks, right? But for pythium, within 5 days, 7 days, the lesion will progress rapidly.
Any comment on depth of involvement? Like many times we see fungal keratitis superficial or not involving like entire depth of stroma. Pythium, it is like more depth in the cornea.
Depth of involvement, right? Actually, in the beginning, if you detect it early enough, it will be kind of superficial, okay? But if undiagnosed, it can progressively infiltrate into the deeper stromal. And as I shown in the figure, sometimes it involves the total cornea.
Can I make a point here? So this again emphasizes that, you know, over the years we tend to take things for granted. We just say, oh, it's an ulcer, and we don't take that care to look at it so carefully. And then we can miss things. So this is again a reinforcement that just because an ulcer, we should not, you know, disregard all that care of looking at it very, very specifically. What are the margins like? I tend to do it a lot. Because I always just say, you know, keratitis, and I feel that, but it's our mistake as well. So we need to, you know, remain that, retain that engagement and that interest in looking at every point, because that's how people have taken care, and that's how they've discovered these things, you know, because it just didn't take it for granted that this is just another infection.
I agree. And the other thing is that if you're suspicious of pythium, what we did at our hospital is that we just call the microbiologist, because these things grow very rapid on the blood agar. So that's another clue in order to, you know.
Yeah, one more symptom, like pain more in pythium or fungal? Any comment or?
Pain? Well, not excruciating pain, just the normal pain that you got with keratitis.
Okay. And hypopion, last to ask, yes. Association with hypopion?
If it's progressed, yes, you will have the hypopion.
Okay, thank you.
Monotherapy with linezolid, topical linezolid.
Yeah, right now, because the other thing that I mentioned is that the pythium collection that we have, it was long time ago. So in that time, we don't have to use of the antibiotics. We used voriconazole, which definitely doesn't work because pythium doesn't belong to the fungal, so they don't have the ergosterol cell wall, right? So right now, we use the linezolid topical combined with the topical azithromycin or clarithromycin. And that works very well, especially in the early phase.
Than the monotherapy.
Not monotherapy, with combination. Yeah.
I think one more point to add on this. I think one of the series of therapeutic keratoplasties done for pythium keratitis from the Shankarnetralia group, they also add on cryotherapy to the margins of the lesions here, and they claim that that is effective in containing recurrences of infections and enhances the successful management or success outcome of their cases as well. So that's something which is an adjunct therapy to your therapeutic keratoplasties. But pythium, always it's early suspicion, it's a fungal looking ulcer but progresses like a bacterial ulcer. Rapid destruction of the corneal tissue, you would see early interventions, early institution of the right therapy, and probably this is one case where one scenario where you would want to do a therapeutic keratoplasty early on, and cryotherapy, combining your therapeutics with cryotherapy yields better results in containing the infection.
If I am permitted, one more clinical picture is formation of that gutter, something like which mimics PUK in pythium. Formation of a gutter in periphery, which can mimic a PUK.
A gutter-like appearance which can be at the periphery along with the tentacle presentations is also something which we tend to see commonly in India. Yes. Yeah. Thank you, Dr. Revati. And now Dr. Revati will tell us how the lessons we learned from MUT have changed the way we manage fungal keratitis.
Thank you, Dr. Vanati, for giving this opportunity. And the need for study like MUT started with the worldwide outbreak of contact lens associated fusarium keratitis, because previously the filamentous fungal infections are more common in eastern countries. In the eastern countries, in the western countries more of candida and yeast like infections. And then with this outbreak of fusarium, renewed interest started. Whether any other antibiotic, antifungal than natamycin can be utilized in case of fungal infections. And at that time, voriconazole was the new drug relatively. So this study is almost more than a decade old, as you can see. And here we studied a double-masked randomized control study where a topical natamycin 5% is studied against voriconazole 1% topical solution. And as you can see here, almost 40% of the isolates were fusarium and the rest non-fusarium. Even in this, the unidentified other filamentous fungi, Dimetaceous or unidentified hyaline fungi were more than even Aspergillus, because this is most of the enrollment occurred in one particular southern state. And the results what we have come across, the primary outcome we took as the vision at 3 months, and also the need for the percentage of medical failure where the surgery is needed. And as a secondary outcome, they have the rate with which it heals, and also the microbiological cure whether we can achieve at the end of a week after starting the therapy. So in the first primary outcome, natamycin definitely stands out much better than the voriconazole, and this reduced the need for therapeutic keratoplasty as well as the visual acuity also was much better in this group. But again, when we sub-analyze, the fusarium group really, it helped a lot. Non-fusarium group, the differences were there, but they are not that significant. And so the convenient conclusion, especially in fusarium keratitis, natamycin is the drug of choice when used as a topical drug alone. But the questions here are, we studied more in fusarium, what about the other filamentous fungi? And again, only monotherapy is studied, whether a combination therapy with voriconazole or any other antifungal or azoles, whether it can give better results, or even voriconazole, whether it is used in other forms, whether it can give better results. Because with 1% instillation, the aqueous concentration is much less than what we need for an antifungal or MIC value. So that is another thing which suggested maybe in other way if we use it, it may be useful. That's why the MUD2 study was designed. Again, around the same time it was started. This is done in more severe keratitis. So one group received both the topical medications and combination of natamycin and voriconazole, and one group received in addition voriconazole tablets, the other group only the placebo. And here again what we found that we didn't find much difference overall in the instance of therapeutic keratitis in both group. But when we analyze only the fusarium group, which is the major group, oral voriconazole seems to have a better edge, because it seems to reduce the need for the therapeutic keratoplasty in this group. Again, this is a little controversial result, which still we wonder how, but maybe, as we said, the oral therapy may be getting better deeper penetration and deeper concentration, and that's how it helps in reducing the therapeutic keratoplasty in these cases. But one side effect what we have to remember, giving oral voriconazole, this was given for 3 weeks in this study, and at that time some of these patients have significant hallucination problem. So this we have to keep in mind, and we have to be alert if we are going to use it, because after this study I at least started using oral voriconazole whenever possible, even after therapeutic keratoplasty if the infection was very severe going up to the anterior segment. After therapeutic keratoplasty, I started using this to reduce the chance for reinfection. And then when we collected such a large number, we also looked into some prognostic factors where we have that very poor medical outcome. Is it due to the recalcitrant infection, or is it due to the uncontrolled host response? Then there are few subgroup analysis which showed if the patient is still positive at baseline, culture positive, even after receiving a pre-treatment with antifungal, then they seems to fail more for medical therapy. Same way, if the patient's repeat culture after starting the therapy after 6 days, if that comes as positive, again this group seems to behave, respond less to the medical therapy. So it may be the actual infection which is causing the problem. Even therapeutic buttons after the therapeutic keratoplasty were analyzed. Again, between the voriconazole group and the placebo group, we didn't find any difference in the culture positivity. That means even with oral voriconazole, one group did not respond to the infection, did not respond to this therapy, which went for therapeutic failure, medical failure. And another last one analysis which I brought to your notice, the azole resistance which we saw during the MUT analysis. The cases which were enrolled from day one, they were compared with throughout the period, we compared the MAC 90 value, and we found that for the voriconazole, MAC 90 value keep on increasing towards the end. So that means the voriconazole resistance is more and more increasing throughout the time, but the natamycin we didn't see such a difference. Dr. Lalita is sitting here, and she's the one who did this particular analysis very clearly. And this may be because the azole is again used in the systemic therapy also, and also it's being used in agriculture in India as a fungicide. But natamycin is used only as a topical ophthalmic medication. So this may be one reason why natamycin is still being effective in filamentous fungal keratitis. So in conclusion, still natamycin is the best drug as a topical monotherapy in filamentous fungal keratitis, especially where the fusarium keratitis is more. And the non-fusarium, still we can have a role for voriconazole or other azoles, but still it's better to use it as a combination therapy. And also there is a role for voriconazole or other azoles as oral or intrastromal or intracameral injections. Still, of course, we all use them. And we have to look for some advocacy against using these medications in other commercial products also. That also we have to keep in mind. Thank you.
I have a question to Revati ma'am. Good afternoon. Very good presentation, very comprehensive. My doubt is, in your clinical practice, where do you use oral antifungals, and which is your drug of choice among all the oral antifungals?
Yes, as I told you already, I use it when the infection is almost going up to the limbus. And of course, generally we don't wait till it goes to the sclera, we go for a therapeutic keratoplasty. But in such severe infections, post-therapeutic also, I would like to use oral. And my drug of choice is oral voriconazole, because I myself studied oral ketoconazole, which I found of not much use. And later even AIMS group also studied this, and they also published it's not that of that much use. But oral voriconazole maybe, I anecdotally at least I found it useful, but only the cost part we have to keep in mind when we are using in our patients.
In which patients do you recommend intrastromal and intracameral voriconazole, and what is your schedule and regimen when you give intrastromal voriconazole?
Again, intrastromal, I personally feel it's better to give before it goes for a full necrotic lesion, because full necrotic lesion is, I think whatever you give, it's not going to respond. When it is in the still in that spreading stage, if it is more, it's a large lesion or more deeper lesion, better, I used to use oral, intrastromal voriconazole, because I feel still voriconazole when given in that area, it might be helpful because the concentration may be better, and I prefer voriconazole. Intracameral also I prefer voriconazole rather than amphotericin B, which can cause more inflammation.
Intrastromal, do you give once and wait for a day and then observe? Then
that is the dictum generally we are being followed, we are following, because sometimes after injection, sometimes we can see it's worsening also. So it's better to wait, observe, and then go for it. We don't know the reason for why it is worsening in some cases. So better to wait for a day and go for alternate day injection.
Last question. We observe that sometimes anteriorly the ulcer heals, and posterior in the deep stroma there is always active, and there is some risk of perforation. So in that case, do you advise intrastromal voriconazole?
Yes, that's what. In such cases, yes, I do try intrastromal, and sometimes even I do try oral voriconazole.
Thank you. Thank you so much.
Comment on your usage of topical amphotericin B in your practice, yeast cases, or after scraping or results from the lab you start, or empirical therapy also you tend to use?
Empirical therapy, we usually go for direct natamycin only, or natamycin with oriconazole, like that, strongly if you suspect. But amphotericin B has a role, especially I feel in case of aspergillus. If it comes positive for aspergillus or dimetaceous fungi, then if your natamycin is not obviously not giving a faster result, then you can go for amphotericin B, definitely. Still it has a role.
Thank you.
Vanity to give her talk on pediatric keratitis and keratitis in dry eye and ocular allergy.
Thank you, ma'am. And I think just to add on to the earlier discussion, a couple of pointers is when you look at fungal keratitis in India, there is a geographical variation on the cornea pathogenic fungi here. So South India sees more of Fusarium, and North India sees more of Aspergillus. That also sort of defines the response rate to the antifungal agent we are using in. So that's something you need to keep in your mind here. And I think internationally we are now looking at the concept of incorporating antifungal resistance modality, study of antifungal resistance in our practice, because this has now become a reality, and I think that has been the basis on which we had looked at two of our thesis students looking at the use of posaconazole in our and adding on posaconazole, topical posaconazole, to our armamentarium of antimycotic therapies which we have. And posaconazole currently holds the lowest MIC against the variety of corneal pathogenic fungi, and is more effective over a wider spectrum of fungi compared to voriconazole. So that's something here. And intrastromals, I per se reserve it to when your surface is healed, when epithelialization has occurred. Please remember, all the antifungal agents which we have a better penetration in the presence of an epithelial discontinuity. So once your epithelial surface is healed, the penetration becomes lesser, and it is in these deep mycotic infections your intrastromal injections are going to be working well. And I always still follow the dictum which I learnt at AIMS, that we add on amphotericin B as an adjuvant therapy to natamycin when we are looking at Fusarium infections here. So these are some simple tips which I still feel and I think still applies to the current practice of managing fungal keratitis here. Thank you, Revati, for those insights as well. So I think we are almost to the end of our end of our thing, and I'm going to talk to you over a variety of pediatric corneal infections here. So pediatric corneal infections, you could pretty much get a variety of these here, and very much like adult. But the only difficulty is we probably cannot do a good slit lamp evaluations in these children, and you will probably need to be prepared and prep up your setup to do an examination and an anesthesia every time you see a child who's not opening up the eyelids and it's not allowing you even a diffuse torchlight examination. So that's something which is different, and probably we do not wait as you would do in an adult case to give a medical therapy here, because this is a child has more longer years of life and you do not want him to lose useful vision. So you're probably going to be more aggressive in the way you're going to be managing these cases. Again, this is a bacterial keratitis in a child here, and the advantage when you do an early examination and anesthesia is that you could probably take up your corneal smears for your corneal scrapings for smear and for culture sensitivity in these patients, and that will help you to guide you in your management of your either an antibacterial or an antifungal therapies. The presentations would be pretty much very similar, but it is that children are more difficult to be examined, and that's the reason why you would probably want to take them early on for examinations under anesthesia here. Viral keratitis in children, we always tend to think probably there's not much of viral, but here adenoviral keratoconjunctivitis does occur in children, and since this is a fleeting and again they do not allow a good examination, we probably tend to underdiagnose these scenarios here. And in India, I think herpetic keratitis in children is a significant problem, and And I think we should not, we do not underdiagnose, or we do not rule these out, and these do not exist. Similarly, as you would have in adults, I think herpetic infections in pediatric age group is a reality here. And when you do see poor ocular surfaces of these children, you're probably going to revise your diagnosis, and you're going to look at what is probably causing recurrent infections in these cases, which could be a secondary infection occurring on a surface which is being attacked by virus time and again. So that's one scenario where probably you're going to be looking at in these patients here. Fungal keratitis, something like this is very typical when you got your diagnosis wrong out, but you also know these are more difficult to treat here, because in pediatric cases I tend to use more of ointments compared to topical medications. As you know, these children squeeze out whatever is put in terms of drops here, and that's going to decrease the effectivity of your medical therapy. So where you have ointments for treating these cases, then your probable success rate, because of retaining the antimicrobial in the ocular surface and the conjunctival cul-de-sac, is better in these cases here. So for fungi, I think the only ointment which we do have available in India is itraconazole here, and itraconazole still is not as effective as you would look at natamycin in the management of. It's only an adjunct therapy here. So that's the reason why when you're looking at mycotic keratitis in children, you please will need to have a closer monitor in these cases. You'll need to have a closer follow-up, and also schedule your patient for more frequent examination under anesthesias, so you can revise your management modalities, whether you want to continue a medical therapy for these patients, or whether you want to take them on for an early therapeutic in the event the child is worsening here. So these are particular scenarios and how it would probably differ when you're looking at the management of these cases. Again, nocardia keratitis is something when children playing in dirty water, and down south of India, nocardia keratitis is a significant pathology which you can occur, and which you will probably need to look at your differentials, and your corneal scrapings and microbial investigations are going to be helping you in this child. This is one of our patients here where the patient developed an acanthamoeba keratitis, but not always would you have a textbook kind of a picture when you're looking at an acanthamoeba keratitis in this patient. And in children, pain is not a very reliable quotient to depend upon, because children do tolerate pain much lesser than the adults here. So your clinical acumen, your clinical diagnosis is probably going to be very imperative in the way you're going to be diagnosing these cases. So do not undermine the importance of doing a good corneal scraping here for smear detection. Your microbial backup and your microbial support is going to go a long way when you are managing your pediatric keratitis patients here. So shifting down to what to have as neurotrophic keratitis in children here. So these do occur as a reality on those surfaces. We do not see so much of Sjogren's, we do not see so much of Stevens-Johnson's as you would see in adults, but then those unfortunate children who do have chronic viral keratoconjunctivitis, you can have a neurotrophic lesion on these patients here. Those who have had very bad Stevens-Johnson's, which has not probably been treated adequately or optimally in the early stages, can have neurotrophic surfaces here, and they can have recurrent breakdowns like this. So you would probably need to rule out a secondary infection in these cases when you are managing these cases as well here. In children, secondary infections secondary to chemical injury. So because these are surfaces where the ulceration is going to be staying on for a longer period of time here, and if the ocular hygiene and the management is not optimal, these are surfaces which can get further complicated by comorbidity of a secondary infection. Commonly could be a bacterial infection in these cases here. So that's something we need to be wary of when you are managing very morbid surfaces which are affected by chemical injuries. And pediatric chemical injuries is a reality in India which we all of us do see more often than you would see in probably other countries here. Again, another child with quicklime injury. In India, we have these children playing with squeezing the lime packets which is used for pan, and it's very sad that this is concentrated lime and just goes directly into the cornea and causes severe damage to the ocular surfaces here. And secondary infections in these cases can complicate because you don't want to do a therapeutic early on unless and until it's really indicated, where your stem cells are all have gone for a toss. So that's something where you probably need to look at these surfaces more carefully and closely here. And ocular allergy, pediatric ocular allergy is a reality, and we do see a lot of these cases in India here. And this one is like a grade 3, grade 4 Shields ulcer, which is associated with a bad giant papillary conjunctivitis here. And these are cases once they have potentially vision blinding, corneal blinding scenarios. You're going to take them on early on for management, avoid a secondary infection in these cases, and help the surface to heal by using amniotic membranes, inlays and onlays here. And these help to decrease the amount of scarring and enhance early healing in these cases here. These are again some more scenarios here where you would want to be cautious of when you would probably not want to do keratoplasty for vision rehabilitating in these scenarios of keratitis, and perhaps you would want to follow a more conservative management of these cases here. So one you see out over here is a child with a neurotrophic with hereditary sensory autonomic neuropathies here, and these neurotrophic keratitis, always be aware, don't touch them here. You would not want to do a keratoplasty. You would probably use adjuvant methods like amniotic membranes for healing the surfaces here and prevent secondary infection. So that is a scenario where you need to be wary of when not to do keratoplasty and when you need to take them up for just conservative management for healing these surfaces and give them whatever vision they probably can get out of these morbid surfaces because of the systemic nature of the disease which affects these conditions here. In India, keratomalacia is still a prevalence. You probably will not see them to that level in urban cities here, but in suburban regions and in tertiary cares, keratomalacia is still a reality because of poor weaning practices, which is quite prevalent here. And keratoplasty for keratomalacia, the results are not as successful as you would do for other therapeutic conditions here. And you would need to watch these children for their protein energy malnutrition management, for their immunization management, for their dietary advice management. So a close collaboration with your pediatrician is essential apart from taking them for therapeutic keratoplasty. So this is one such child which I had done recently here, along with the secondary infection, so needed a therapeutic keratoplasty, and see the surface and the graft do not do so well. You probably will have to take them back to your OR repeatedly to manage the suture loosening, the epithelial defects not healing here. So it is a condition which needs close attention, and it is a challenging scenario to be handling in these cases. Those cases which have healed keratomalacias, rotational autokeratoplasties does work well, especially if they are one-eyed children here. So that's a consideration if you want to do visual rehabilitation for these cases. Yes, we've already touched upon optimal management for the surfaces affected with neurotrophic keratitis and because the dry eye because of Stevens-Johnson's. These are again cases which get referred to us from our plastic colleagues here, and here it's because of all the congenital ectropion, the microblepharon, and the malformations of the ocular adnexia. You would find neurotropic conditions which need to be managed optimally in these cases here. I think we touched upon more, but blepharokeratoconjunctivitis in children is also a reality. Before I move on to that, you have atopic keratoconjunctivitis and ocular allergies. So in Indian children, you tend to miss them more because of the color of the skin. The eczema gets missed more often in these patients, and the tendency of increased symptoms in these patients, the tendency for eye rubbing, the occurrence of keratoconus is more severe in cases of atopic keratoconjunctivitis affecting children here. We've already seen this, and I think in the interest of time, I would not want to go into more details of managing ocular allergy, but something which really does help and which I do follow in most of my patients is the use of tacrolimus 0.1% eye ointment over the lids of these patients. Intraocular topical installations of Talamus in children is usually not tolerated very well here. So application of the ointment over the lids works well in these cases, vis-a-vis you're looking at adults here, and this also helps to manage the tarsal morbidity in these cases here. So I think there is more to discuss on these. We'll stop here, and we can probably take more questions in the management of these cases here. Thank you.
Can I ask Vivian a question? Have you seen pythium in a child by any chance? Or pythium? Is it pythium or pythium?
As far as I can recall, most of them are adult, not in childhood.
And also for some reason post C3R infections, even here we don't see fungal infections much. I don't know why, answering his question. Even in post C3R, yeah, we don't see fungal that much.
I agree with Dr. Revati that post-collagen cross-linking infections tend to be more either immune sterile infiltrates or they tend to be bacterial infections. Most of them are coagulase positive staphylococcus, which we see in our scenario as well. So we don't see so much of fungal infections in these cases. Yeah.
Other thing, these cases when they go for therapeutic keratoplasty, for some reason the grafts survive very well. Reinfections or even graft failure is relatively rare in these cases. So the C3R does something there.
Ma'am, do you advocate systemic vitamin A supplementation for pediatric corneal infections? Do you give to your patients?
Only if it's keratomalacia, and then we follow the protocol of the first day and then 24 hours later, and then after 14, the 2 lakh international units orally is what we prefer. So otherwise, not otherwise.
And ma'am, for shield ulcer, which steroid you prefer? Or like it's like PUK, first you start with antibiotics and then after 2 days you start with steroid.
Yes,
Or
for
straight
PUK, the question is for PUK.
Ma'am, for shield ulcer.
For shield ulcer,
Yes,
okay.
ma'am, for both like PUK also it will be nice to know. Which is steroid of your choice. Yes.
Yeah, it's a good question. The two thing is how potent it should be, and I generally prefer a solution to a suspension.
Yes.
So if I'm very confident and I've ruled out the infection and I'm sure that it's an inflammatory, I will start with prednisolone. And I prefer prednisolone phosphate because we get it in North India and it's a solution. I don't tend to use dexamethasone because it makes the intraocular pressure go higher. So we use, first choice would be prednisolone phosphate. If I have a doubt that I'm not sure, then firstly, and also when I give the steroid, I don't give it very frequently, 1 hourly, 2 hours. I'll just give it 3 to 4 times a day and reassess the patient after 3 to 4 days. If I have a doubt, I sometimes even use fluoromethalone and then reassess. So that's it.
Thank you.
Thank you, Dr. Vanathi, for a great talk.
Yeah.
A general observation that I have, and I wonder whether it's the same in India, is that in broad terms, you get much more secondary inflammation with childhood corneal infection. I never see an isolated, for example, dendritic ulcer in a child. They all get additional stromal inflammation, which is not the case in adults. And you see, immune rings quite often in infections,
Yes.
and these are very, very unusual in adult disease.
Yes.
So I think the use of steroid as an adjunct in keratitis in children is something we really need to do trials on.
Oh, yes.
But thank you
Yes.
very much for your
Yeah.
presentation.
Yes, yeah. I agree. I agree with you on that. And to add on to your question on steroids in children, I tend to use loteprednol ointment formulations are available in India here. So it's only because they do not allow free installations and they don't stay on the surfaces. So using the ointment forms of loteprednol is something. And I do agree with what Dr. Larkin's observations on you do see immune rings and you do see inflammation components to be higher on the surfaces in pediatric cases here. So that is a reality here.
Thank you, ma'am. Thanks a lot.
Thank you very much for being with us in this lunch session, and I hope you enjoyed it as much as we all enjoyed sharing our experiences with you. Thank you again. Take a picture, just 4 of us.
Yes, ma'am.